Good morning, ladies and gentlemen, distinguished dignitaries, colleagues, partners, and friends. It is my privilege and pleasure to welcome you all to the fourth annual conclave of the Global Learning Collaborative for Health Systems Resilience here at the Indian National Science Academy, New Delhi, which makes a fitting home for a gathering such as this. On behalf of the conclave hosts, GLC for HSR, Access Health International, National Center for Biological Sciences, Tata Institute for Genetics and Society, and in order, the Health Systems Institute, we're honored to receive this August gathering committed to one shared purpose: building health systems that do not merely survive shocks, but learn, adapt, and emerge stronger through them. This conclave is the annual flagship convening of the GLC for HSR, a global cross-learning platform founded in the aftermath of the COVID-19 pandemic. At its heart is a simple but powerful idea. Resilience is neither a slogan nor an abstract aspiration. It is the outcome of preparation, coordination, evidence, and implementation. Today, we gather amid overlapping pressures on health systems globally as they struggle to ensure equity and quality. The conclave asks a question of consequence. How do we move from resilience in theory to resilience in practice, from what we know to what we do, and how we sustain it? Some of you may have wondered why we chose the tandem cycle as our visual identity this time. The reason is we imagine the health system as a shared vehicle of progress and each subsystem as a part of the whole. It is built component by component, connection by connection, and action by action until the whole system can move forward with stability, purpose, and strength, just like a tandem bicycle. Over the course of this conclave, the dialogue will traverse across a set of deeply interconnected themes that are not isolated subjects, but in fact, the very architecture of resilience itself. Over these 2 days, learning will not remain at the level of ideas alone, and it will be grounded in lived experiences, comparative practice, state and national level examples, and peer to peer exchange across regions. To formally commence this conclave, we are privileged to be joined today by a stellar lineup of leaders on this inaugural plenary. But first, it is my pleasure to call upon our very own Dr. N. Krishna Reddy to set the context. CEO of Access Health International, a distinguished cardiologist, institution builder, and a health systems leader, Dr. Reddy wears many hats. He has helped shape both healthcare delivery and indigenous innovation in India. His work reflects exactly the kind of systems thinking this conclave stands for, combining clinical excellence, access, affordability, and resilience. Dr. Reddy, I request you to formally open the conclave.
Good morning, everyone. I think this has become our annual gathering, get together. I think a lot of people I do see who have been attending for the last 3 years. And thank again for coming early morning. But we said we have to start irrespective of people coming or not coming on time as a part of our culture. GLC was conceived on 1st September 2021, which happened to be my Shashtapurti actually. So that's coincidence. Then it was born on 11th March, the date on which pandemic was declared. So today is fourth birthday, fourth birth year and birthday. So it was a toddler, I think slowly. The original father actually abandoned, that is Rockefeller Foundation left after 2 years. So Access Health is continuing the child to its intended purpose which Stuti has already outlined, that how do we contribute to the evolution of health systems to become more stronger, more secure, and more resilient through the means of collaborative learning. I mean, this is a powerful mean of collaborative learning. How do we do that? We adopted a governing principle like any organic evolution. The GLC should be self-organizing, self-governing, and self-sustaining. I think we have been evolving in that fashion, in an organic social fashion. It's not a mechanistic structural design which puts a constraints on any organization. It does not evolve in response to emerging situations. And our means of this impact is through the virtuous cycle of knowledge to action, action to knowledge. The Jnana Yoga to Karma Yoga and Karma Yoga to Jnana Yoga. So that is what I think in the first 3 years of the GLC, we have been going through an interesting dialogue from various researchers, academicians, and the practitioners on the very understanding of health systems, because the health systems has been evolving conceptually. I mean, what was building blocks is totally different today. Because in the building blocks, people were not there in the center. People were excluded from the building blocks. So that concept of people being in the center, in response to whom the health systems organize themselves. So the needs of the people keep changing. The determinants of their health keep changing. The crisis that they are facing is changing from monocrisis of pandemics to polycrisis. I mean, today we are living through the polycrisis. Similarly, the idea that it has to be looked at only from the global lens has been transformed into local to global. How you look at health systems locally is different from at a subnational, at a national, at a regional, at a global level. So that concept has changed. Then there is theoretical conceptual expansion that health system does not function in isolation. It is interconnected and interdependent with other systems, led to the concept of whole of governance, whole of systems, whole of society. But how are we operationalizing this concept? I mean, that conceptual understanding is clear, but we are not able to operationalize it. So this is the objective of some of these learnings is how do we operationalize these conceptual clarities and understandings that emerged out of these learning sessions. Similarly, the whole concept of One Health, I think, again, everybody is very clear. Everybody accepts the concept of One Health, that the human health is dependent on animals, the plants, and the environment. But how do we, again, operationalize that concept of One Health? Are the people, animal husbandry, environmental sciences, human sciences, are they getting together around one table to share how we can collaborate and coordinate in the surveillance system so that we can establish the interconnectedness between the animal health and the human health? So again, I mean, these are some of the ideas I used to describe in the previous GLC sessions, that our learning is like a river. We converge every year on the annual conclave, different themes, different sub-themes, different issues, different problems. Then again, we diversify during the next 12 months to continue that learning journey. Again, reconvene every year until we reach that purpose which Stuti has outlined of the GLC. It's like I used to describe the example of the river traveling towards meet the ocean. It's destiny. So the destiny of the GLC is that purpose of how this collaborative learning can enable evolution of stronger, secure, and resilient health systems. From what learned in the conceptual these understandings, I think this session, as the theme illustrates, from resilience theory to deployable action, the theory to action, that means the knowledge to action. So this session actually, we will be giving more emphasis on listening to the practitioner's viewpoint. I mean, practitioners who are attempting to transform healthcare delivery through care coordination. Practitioners who are trying to drive value of services through strategic purchasing. Or strategies which are acting purely at the community level in terms of the health literacy, behavior change, participatory governance, self-care, to empower people at the community level independent of health systems. So in cross-cutting all these, the systems and subsystems, I think every session will be talking about how the power of digital technology will enable some of these transformative changes that we are thinking of. I mean, very concept of care integration will not be possible without an integrated, interoperable health information system. So these are the powers of digital health, but at the same time, I think the session is going to also discuss, we should not forget that we should not create a new divide, the rich-poor divide, literate-illiterate divide, rural-urban divide, digital literate and digital illiterate divide. So that's where I think there is a discussion on what is the responsibility and accountability of the governments to invest into the digital transformation so that there is equitable transformation. It's not just a few select people are getting benefited by the digital transformation. So these are, I think, some of the sessions in the next. We may not be able to cover all the issues that are burning, but we hope we will cover whatever can be covered. I mean, it should be a kind of a. We always believe that learning should be enjoyable experience. I mean, we want people who want to learn, and with the idea that some of the ideas act like good viruses. They will multiply in your brains, and some of those multiplication leads to actions. I mean, some of you who are in the policy making level or policy decision level, those ideas you may be able to take home and then put across a pilot in a district, in the state. I think that's the purpose of this learning, how it can stimulate. It will multiply because ideas will never die. Ideas will multiply and keep troubling the people that why I can't test this idea. So with these few, I think, opening remarks and the purpose of the GLC, I hope we will enjoy next 2 days. The very rich, I think we have one of the best speakers with rich experience and the rich wisdom. You can't have better speakers than what we have gathered for the next 2 days. So I wish that each one of us will enjoy this session. Again, in closing, I welcome all of you to be part of this family and continue to take that journey towards the ocean of knowledge.
Thank you, Dr. Reddy. As always, your words are simple but have profound wisdom, and we continue to take inspiration from them every single day. To begin with, it is my absolute honor to welcome Dr. Rajan N. Khobragade, IAS, Additional Chief Secretary, Department of Health and Family Welfare, Government of Kerala. Sir, I request you to please take a seat on the dais. A medical doctor and a senior administrator, Dr. Khobragade is widely regarded for system stewardship during periods of crisis, including Kerala's highly acclaimed COVID-19 response, and with efforts such as the state's One Health approach. His experience speaks directly to what resilient public health leadership looks like in practice. It is a privilege to have you amongst us today, sir. We're also pleased to welcome Dr. Amit Kumar Ghosh, IAS, Additional Chief Secretary, Department of Medical Health, Family Welfare and Medical Education, Government of Uttar Pradesh. As a senior administrator with over 3 decades of experience, Dr. Ghosh is serving one of India's largest and most complex governance environments. He represents the importance of state leadership in translating policy ambition into public systems that deliver at scale. He has held several senior leadership positions at the central as well as state level. We are humbled and honored by his presence today. We are deeply honored to welcome Mr. Manoj Jalani, Director, Health Systems Development, WHO Southeast Asia Regional Office. With decades of public service and global health leadership, and as one of the principal architects associated with major health reforms in India, including the Ayushman Bharat, Mr. Jalani brings a rare perspective on how policy, financing, systems design can come together to advance universal health coverage and resilience. We are grateful, sir, for your continued support to the collaborative and extend a warm welcome to you. It is said that good science is the foundation of good policy, and few individuals embody that principle as powerfully as our next speaker. Please join me in welcoming Dr. Sangamitra Pati, Additional Director General, Indian Council of Medical Research. A highly respected physician scientist, Dr. Pati's work has advanced research, innovation, and evidence generation in areas central to public health preparedness and systems performance. Her presence underlines the critical role of science in shaping policy-ready and implementation-ready solutions. Honored to have you with us, ma'am. We are privileged to welcome Professor Mala Rao, Senior Clinical Fellow and Director of the Ethnicity and Health Unit at the Imperial College London. A global authority on public health, equity, and the health impacts of climate change, Professor Rao has helped broaden the way we understand resilience, not only as service continuity, but as justice, inclusion, preparedness in an era of environmental risk. We are delighted to have her with us today. Last but not the least, it is our pleasure to welcome Professor Brajesh Pandey, Executive Director, Indian National Science Academy. We are grateful for his presence and for the support of an institution that stands at the intersection of scientific thought, national advancement, and intellectual leadership. Thank you, sir, for your support to this convening for the second year in a row. And we request, sorry. So, as I said earlier, it is a stellar lineup indeed to kick off the proceedings of this conclave. I invite first Dr. Rajan Khobragade to please come forward and address this august gathering.
Distinguished seniors on the dais, my colleagues, and all the fraternity who is working in the health tirelessly. Uh, Welcome to this conclave. At the outset, I thank Dr. Krishna Reddy and his team for giving opportunity to me to be with you. He has been, asking me to be there last year also, but I could not come. But then I told him that this year definitely I'll try to make it because there is a lot of learning. Before I go to my few points, what I would like to share in the inaugural speech, he explained us this tandem cycle. I was asking to my colleague also why it is done. So it is very rightly mentioned that any system which is built by the parts and each part has to work. But a thought came to my mind that when what I experience is if the cycle is on the treadmill, it will be running, but it doesn't go forward. And that is what we invariably experience, even though there are a lot of learning lessons what we have been doing in past last 20, 30 years, that the systems are there, processes are there is a good knowledge, there are everything is in place, but unless and until we act on it, it doesn't go forward. So it is a very rightly chosen the design. Only one addition is that we also mention that it is not on a treadmill, the cycle is on the road, and then it always goes forward. So that is what the thought came in my mind, and in that perspective, when I look back, I'll touch upon 3 points related to this whole affair. Whether whatever we are seeing, what is happening around us, whether we really deeply think over it and act. So first thing come to my mind is, that is what also touched upon in introductory speech, is One Health. So when we were going, in fact, One Health is not a new concept. Our forefathers, our saints, everybody told that we are all world, we are all one, and we are all dependent. I think they got that wisdom out of their very deep study or meditation, whatever you call it. But those messages and those practices were there in our society. I think as we advanced, we have tend to be going in unidirectional level, and then multiple direction, and that is why I think there was no association and there was no synergy to understand what actually is happening in the environment. So when we were experiencing the COVID pandemic, at that point of time, there was a discussion with World Bank, and then they said that okay, in Rebuild Kerala initiative, there has to be a health component, and they had a discussion with us. I don't know, some of the I think colleagues from the World Bank perhaps may be attending today or tomorrow, or they may be here now also. So we made it very clear in the state of Kerala. In fact, whatever you are suggesting is already done. So if we have to take a challenge, then we need to take a One Health concept forward. And very readily they agreed. And that challenge we have taken in the midst of the COVID pandemic itself, because we need not wait that if we are having one emergency, we will come over with that emergency and then we will think because we have learned a lesson. We have to do multiple things at the same point of time. So in 2020, we have discussed 2021, we launched One Health program in 4 districts. And in that 4 district, because that is the part of the project, so that was in a Pamba basin. So we have built the system which is involving community. What we wanted, we were knowing that we are having a surveillance system in health. We are having surveillance system also in our line departments like animal husbandry, fisheries, water sector, forest, everybody else. But how best we can involve community, taking their involvement during the first phase of COVID pandemic. We started working on that concept, and at every panchayat there are 268 local bodies falling into this 4 district. There we have trained more than 2 lakh volunteers. We are having a line list and we have done the training at a community level, so we know that which volunteer belonging to what ward in the panchayat. And we told them the basics, that what all the very unusual sightings which are there in the vicinity, that you can inform to us. So early warning sign, as easy as a very huge mosquito breeding to a death of a monkey, that also should be reported, because if monkey deaths are happening unnaturally, then there is a also the input is to us, there may be a KFD now spreading in that particular area, and then you need to take care of all those issues. So it is really very satisfying when we are looking at this, the one layer of the what we call it a community surveillance in a structured way. In fact, that is what we have put in place. And for governance, we are having those respective ward members and the health standing committee chairman and the health standing committee at the panchayat level. And then we are having the similar structure at a block and the district level. And then we have given them a training that very unusual anything is sighting. For an example, if the bat roosters and the bat, death of a bat or something, or the birds or migratory birds, if we are noticing the death, then there is also a worry related to H5N1 and all that stuff. So basically, learning from the lessons what was happening in the past. In fact, we have building a structure at the grassroots level onwards up to the state level, that there will be a information flow, and we will ensure that we will go ahead in a very systematic way. Now, the convergence is a very easy word, but it is very difficult to do. Because we also experience at a union level. In fact, Manoj sir may be knowing that if in order to get ministries coordination and also getting the guidelines drilled down up to the state level and sub-state level, it is a Herculean task. But what we have experienced is the nearer to the field if you go, the convergence is very good. So what we have done is all the line departments functionaries are also part of this. And the most fundamental thing that what we are discussing now at the Principal Secretary, Scientific Advisor to Honorable Prime Minister, there is a committee which is working on a One Health project. That we have made it very clear that we should not make it as a one department's agenda, One Health. It should be everybody's agenda. So we have to have a very creative kind of a structures and processes even at a district level. District collectors are heading, but at the same time, the convener can be done by rotation. So every department feels that they are having an equal role. So these are some of the structural inputs, what very successfully we are doing it in our state. So that is one area which, I feel that we should be very aware of, and we need to do many things. So One Health, there are fantastic documents, international organizations and everybody, including Government of India, we are having. But whether the action actually started at the field level, that is the question all of us we should ask. And then that question will lead to some of the answers that yes, in my state, in fact, there is something is happening or nothing is happening or something better is happening. So we are at a different levels. My assessment is, we have acknowledged the fact that the One Health is required, but there is a huge work which we have to do it with a sense of urgency. The second point, what I would like to highlight based on the experience is related to zoonotic diseases. When we talk about any zoonotic diseases, I think the question comes throughout the country. that why these zoonotic diseases are and also only in Kerala you are detecting the cases. In COVID, when we discussed the first thing, in fact, everybody else was thinking that COVID will not come to their state, and they were asking why only in Kerala and all that stuff. And then I gave an answer twice, thrice, and then I stopped. I said, okay, you just see that what is going to happen. In fact, next day, and we alerted everybody. In fact, what Manoj sir also knows the whole trajectory. The point I am trying to make here is the zoonotic diseases, because I think the climate change and all, there are many things which are happening into the flora and fauna and also animal world. Now that in-depth analytical point, unless we are having at a state level, we will never understand that what is going to have a spillover effect, and we will have some kind of a very, very difficult situation. So what we have done related to zoonotic diseases is based on our experiences, and I will recall in a time frame. We were, we had a Nipah outbreak in 2018. And then after that, I was principal secretary then, but fully in charge of the health department. I was given on the 1st June 2019. I came to Delhi to call on Priti Sudhan madam. He says, go back. I said, what happened? He said, there is a Nipah outbreak in Ernakulam. That was on the 3rd June 2019. So I went to Ernakulam without calling on madam. And then I landed up in Ernakulam, and with the team, we started working. I realized there is a phenomenal gap in the structures and the processes, even if we had a very good management in Kozhikode. And then right from the scratch, we started that there has to be structures like institutional medical board. Then we have to have 26 different committees with very structured roles and responsibilities. And then a drill that what work they need to do throughout the day and what feedback they need to give in the evening in a time bound manner. And based on that, build a feedback loop each day activities you arrange. To the extent that our now volunteers, they identify the houses which are locked, and whether they were locked prior to the outbreak or during the outbreak. That depth we go now, because we then track them. If they are post outbreak, they are traveling from that epicenter of the outbreak, then we track them and we ask them that you be in the quarantine for some time, because there is a possibility that through you also it will spread in many places. To that extent, in fact, now we have built the system. So that is what we are doing related to the zoonotic disease. And I must say with a pride that the Kerala Health works based on whatever experiences we are having. We think ahead, and we see that in fact we go ahead in a very systematic and a scientific way, and we don't compromise with the science. Because if we go back and if we do back series analysis, there was a lot of propaganda even at a various level. I'll not get into that detail, thinking that the whole program which is going, in fact, why the numbers are huge in the only in the state of Kerala, but that is not the reality. Whatever the numbers are there, honestly we declare related to that, then only we will understand the problem. And if we understand the problem, then only we can find the efficient solution. So my request to all this fraternity who is here, who deeply believe in the science, in fact, we need to be, very vocal during such kind of a time, especially when it is of a epidemic and pandemic proportion. And on that front, in fact, I see that we have got only support from two, scientists. One is a Dr. Jacob John, and second is, our, Madam Dr. Gagandeep Kang, because they were the very clear regarding what pandemic is happening in our country, and they were they were supporting us. So what I want now, if we want to build the future system, that it is your and my responsibility to see that what is science that is telling us, that we have to put it on forefront, because the people who are here as expert, in fact, they are having that kind of a responsibility to mention that what is correct, that has to be done. So that is related to zoonotic disease. That is what we are having a very good method. So there are 2 points. One is post event. Now today I am sitting here, and if the information comes that there is an outbreak of Nipah in Palagat, I need not run, or my health minister need not run, my director need not run. Within 4 hours, and in some of the district within 2 hours, the whole structures and the processes will come in place. The district administration takes the meeting, 26 committees who are all the members, that is known in the schema. What are their roles and responsibilities already there? They come in place. and then they go ahead and tackle the problem the way we have been doing in the past. And that is learning. So in other geography, whether we have reached to that stage, that question we should ask. And it is our responsibility to see that, in fact, the system all over the country, even outside the country, we need to build in this way. Because we have gone through a tremendous kind of a, issue during pandemic. And the pandemic has affected, I think, each and every families in the world and all over the way we have been, working and acting. So this is what we have done, and we are very confident that the post-event management we do copybook style, incremental increase qualitative that we will keep doing. But that is something fantastic. I request all of you anytime, in fact, during normal time or even otherwise, in fact, you can visit and see what things have been put in place and what kind of a capacity we have built in a common man, and also the structures at the grassroots level. The point what Dr. Reddy mentioned is our investment should be in people, and that need not be only restricted to the health fraternity. And if we do that, in a huge way, I think that is more sustainable and our problems will become minimal. And we will definitely achieve the cost optimization of doing intervention. My last point is, if the question we should ask, do a thought experiment. We have gone through the pandemic. What are we doing, in fact, now in every place? So whether we are having pandemic preparedness plan or pandemic management plan, you ask this question. There are, I think, more than 5 lakh gram panchayats. So, do we are having now capacity, or have we built the system in all these 5 lakh gram panchayat? In my state, in fact, there are 1,000 plus gram panchayat. Have we built the capacity to cope up with the situation? Have we done the resource mapping, that what all resources we require and what we have tapped during pandemic? Have we built the capacities of the human resource working in the health, and not only in the health, but also in the line department and also people at large? So I am very happy to tell this. We are in a place, and perhaps that may be the only geography, that in another 1 month we will have pandemic preparedness plan of all 1,000 gram panchayat. We will have the convergence at the block level, because NHM gives now there is a block, epidemiologist. In one block, there are 5, 7 panchayats. So they are doing studies. At a panchayat level, I have asked them 60 different layers of information. So you imagine, in fact, in what depth we are doing this work. At a district level, these layers increases, and we will have a very, very robust planning. Based on that plan, we will roll out the capacity building, and after the capacity building, like I think Japan or some other countries also, they do annual mock drill. We also imbibe that principle. We will have that. So going forward, what we are trying to do is to how to build Kerala health system. So there we would like to, post event, I already mentioned. Post event, what all things we need to do, that we are doing it with utmost efficiency. Prior event, what kind of a structures, processes, and other requirements which are there, that we are building it up. And I think very confidently, in fact, we will be doing it going forward. So this is related to overarching some of the points what I thought in the inaugural session I'll mention. And I, once again thank Dr. Krishna Reddy and all of you, for giving us this opportunity to share some of these experiences. Thank you very much.
Thank you so much, sir, for those valuable insights. Your remarks remind us that resilient systems are built not only through vision, but through administrative resolve and institutional leadership. I now invite Dr. Amit Kumar Ghosh to kindly come forward and address this gathering.
Dr. Reddy, Mr. Manoj Halani, sir, Dr. Rajan, Mrs. Pati, other distinguished panelists, and colleagues in the hall. Once you hear the Kerala model, then you realize that how much responsibility is upon the shoulder of someone who is helming UP, because every sixth person belongs to UP. But let me just say that I'm really pleased that I was able to hear in part Dr. Reddy and in complete Dr. Rajan Kobragade. Last decade, when Mr. Jhalani was a JS, I used to be the longest serving MD NHM. And I used to think that, I know a lot about the system. But the fact is that the times have changed. Now that I've gone back after about 8 years in Delhi, I have found that, even in a state like UP, expectations from the health system have really changed and evolved amongst the people. And somebody was mentioning that, the poorest person who comes to the PHC, average costing, if we do, we give them 3 days medicine. So we pay them about 12 rupees worth of medicine and he goes back happy. His expectation is not large. His expectation is that 12 rupees of medicine and is quite happy that he has been attended to. This rises to about 22 rupees if he comes to CHC and about 60 rupees if he comes to the district hospital. Not more. And this is now at this stage. But the fact is that building or rather orienting the UP system for resilience is a challenge and a lifetime's work if one can do it. We have about 3,000 plus PHCs and 960 plus community health centers and 300 district hospitals, including special hospitals, which we call them at district headquarters. So system is large, but frankly speaking, we have a deficit of about 9,000 doctors. Happy to mention that in the last 8 years, we have opened about 43 new medical colleges in UP, and of these, 28 are in the government sector. I think in the next 5 to 6 years, we will have enhanced supply of doctors. Same goes in the same scale we have done in the area of nursing, and in the same scale we have done in the area of paramedics, and which are now called, they're called healthcare professionals, and a new All India Council has been put in place for them. So on all these, at all these levels, the numbers are rising, and I think that in 5 to 7 years we will have. Because it comes to my mind that Mr. Jhalani had come to UP and said, he asked me, go to KGMU and recruit one doctor and show me that if you can recruit one doctor from the King George Medical College, now university, and get him to your system, him or her to your system, I'll be happy that you have done your job. So from those days, I'm happy to tell you that I run across postgraduates from AIMS Delhi who are now working in UP, and it was really eye-opening for us. But we really, if we see, if we hear what Kerala has done, we have a long way to go. And building resilience in that sense is something that remains a challenge. In fact, I was supposed to go to Kerala the 20th and 21st, but I had to stay back because I was asked to stay back for something. And my mission director had gone with the ex-chief secretary, Mr. Manoj Singh, who is now the CEO of the state equivalent of Niti Aayog. They had gone to study how to lower MMR and NMR. But I'm sure when I get to meet them, I will be able to learn from them about their observations about this part about which Dr. Rajan just spoke. So I think I will now not talk about, we have actually started working on One Health after having attended the national conference here. But there are lessons for us in the Gram Panchayat based model, which has I have just heard about. However, we are way behind when it comes to the MMR and NMR figures also. And we have set up a task force because I think that this decade is the last chance for us to, try to catch up. We have come from about 700 to 140. That is our MMR now. Whereas it should have been 70 by now as per the SDGs. So we are way behind, and that is how this team also visited Kerala. Uh, I We are now focused on saving the lives of mothers by focusing on what is going on throughout the pregnancy. In fact, there is a debate that uh, should we enhance the number of ANCs in our state. So, in a large state like UP, when you try to do something, you cannot do a pilot in 4 districts or, with 75 districts. To make an impact, you have to have something to do with 25 districts at least. So, uh, the second thing that we are finding is that I really do not know whether I should, that now NHM is not supporting the social mobilization network, the NPSN, which was NPSP earlier, and the including the even network of UNDP. So a few states I understand have done away with these, but I have got in touch with NHM and they have agreed to support it for UP for the next 6 months. And after that, we will take over the entire funding of these three agencies. And the government of UP has said that we have to do this continuity of care we have to provide. So I'll be interested in talking to Dr. Rajan as to what Kerala is doing in this area, especially NPSN, because surveillance you were talking about, and you were talking about that model of surveillance where you have already involved volunteers at Gram Panchayat level. We have a large number of these people, field monitors, and how we are able to, continue the model at least which has been bequeathed to us is what we are working on right now. I would like to say that the lessons learned during COVID-19, they do underline the need for preparedness and real-time data systems and very strong institutional frameworks. These are the lessons that we also hear from the field experience in Kerala. So we will try to move towards them. One big thing that we have done is that as far as PM Jan Ayushman Yojana is concerned, we are now the largest such service provider in the country. And that has alleviated the deficit of health personnel to some extent. We are now focusing on three areas, sir. One is we do not really have an emergency and trauma care network of any note in the state. So we have come up with a 5-year plan, which we have drafted in the last 3 months, and a 5-year plan to double the emergency and trauma care in the state. Secondly, what we are doing is we have very primitive, I would say, and very small cancer care network. So that we are building a 10-year plan to make an attempt at providing these services to our people. We wish to focus on governance for outcomes, as we said. So we have a lot of data, but now we are trying to see whether how we can utilize that data. Over the years, with the help of IHAT, with the help of NHM, we have a large number of data and data collection. But when it comes to decision making, That is still a very big challenge. Looking at data and then trying to find the real models, so this focus on science, which you spoke about, that is definitely a challenge for us and a challenge worth attempting to achieve. So this conclave is very important. I have a couple of colleagues here who will be attending till tomorrow. So this kind of conference is very important, and I would like to say that if Dr. Reddy could consider, would like to have a follow-up conference. Not this is your once a year conference. This conference is once a year, but something on resilience for UP, I would love to invite and host and organize. So that is my request to the forum here. Thank you very much.
Thank you so much, Dr. Ghosh, for those powerful and thought provoking words. Your remarks have further set the stage for the conversations ahead. I now call upon Mr. Manoj Jalani to come forward and address the audience, please.
My friend Dr. Krishna Reddy, my distinguished colleagues, fellow speakers, Dr. Rajan, Amit, Dr. Sanghmitra Pati, Professor Mala Rao, Professor Brijesh, friends, good morning. It's a privilege to join you at this fourth annual conclave of the Global Learning Collaborative for Health Systems Resilience. I sincerely thank Access Health International and partners, and I'm personally delighted to have been part of this journey every year over the past 4 years. And this journey has, in fact, evolved alongside and complemented our regional PHC forum, where Access Health has been a founding partner. Friends, the COVID pandemic, and particularly the Delta wave in our region, laid bare both the strengths and also deep vulnerabilities. During the pandemic, every country in WHO Southeast Asia region experienced disruption of essential health services. And at its peak, more than half of the essential health services, including primary health care, were disrupted. And 1/3 of the countries in our region reported interruptions in essential health products. The human and economic costs have been staggering. In the WHO Southeast Asia region alone, COVID-19 resulted in over 6 million excess deaths, direct and indirect, which is nearly 40% of the global total. Between 90 to 120 million people were pushed into extreme poverty, 60% from the World Bank South Asia, as per their estimates. And the global output losses are estimated at 13 to 15 trillion US dollars between 2020 and 2023. And these numbers remind us of a fundamental truth that health emergencies are not just health crises, they're economic crises too. There's no economic resilience without health system resilience. But the pandemic also showed us something equally important, and that was that countries with strong primary health care that included essential health function capacities were more resilient. And let me also emphasize another critical point. There is only one health system. The same health system that is supposed to advance universal health coverage is also expected to ensure health security during emergencies. There's no other health system. So the UHC and health security are essentially two sides of the same coin. And resilience is what really brings them together and ensures both advancement of UHC and health security. And this is why the theme of this conclave is so timely and so powerful, from resilience theory to deployable action. So we already know what needs to be done. The real challenge is about the how. How do we make it work? How do we make it work at scale and real systems for real people? First, and most importantly, primary health care must be at the center. Now, WHO has defined primary health care through three interconnected pillars: integrated primary care and essential public health functions, multi-sectoral action, and empowered communities. We know the PHC approach is it's cost effective, it's equitable, it's critical not only for advancing UHC but also for health security. It strengthens public health capacities for all hazards, emergency risk management, and is also highly effective for prevention and management and long-term care, the needs of which are continuing to rise. So in a sense, PHC enables us to the three P's of WHO: promote health, provide health, and protect health. The regional PHC strategy and the regional PHC forum essentially discuss on how to operationalize PHC with 12 interconnected action. The second, resilience requires a whole of government and whole of society approach. This means strong national and subnational leadership, cross-sectoral coordination, engagement with the private sector, and trust with the communities. Importantly, this cannot be ad hoc. We need institutionalized platforms and institutionalized mechanisms for this coordination, for this accountability, and for sustained action. Third, and perhaps most critical and relevant for today's discussion, health systems must become learning systems, systems that learn from success, that learn from failure, and adapt continuously. Monitoring tells us what's happening, learning tells us what to do differently. In fact, when I was listening to Dr. Rajan and I was reminded of the Kerala experience, so if I recollect correctly, in the first Nipah outbreak, we didn't have clear answers. And of the 22 infected people, 21 died. Okay, that was the fatality, case fatality. The good thing was they could contain the exposure. But then they learned from the success, they learned from the failure. And in the next Nipah outbreak, there were no deaths. And that is what the learning health systems are about. And when I was Dr. Rajan mentioning about science, that was music to my ears, because this World Health Day, the theme of this year's World Health Day is solidarity for science, and with focus on One Health. So very, very, aligned with what Dr. Rajan was speaking. Fourth, financing. Without financing, there really can't be any resilience. Pandemic caused losses of 13 to 15 US trillion dollars in 3 years. And yet the experts estimate that investing just about $1.30 per person per year could close major preparedness gaps. So the preparedness costs billions, while pandemics cost trillions. And yet, we risk falling back into the familiar cycle. You have crisis, you have panic, suddenly enhanced investment, crisis over, you forget, again, investments go down. We need to break that cycle. What we need is sustained investment and particularly domestic investment. Of course, in India, it's essentially domestic investment, but there are several countries like Nepal and all which need to enhance their domestic investment. Bangladesh as well. Smarter spending and value-based financing. I think there's some discussions there because the cost of inaction is far greater than the cost of preparedness. Fourth, leveraging digital and AI in health. Now imagine a health system where real-time data flows from primary care centers, laboratories, pharmacies, social media, is integrated into a national platform, analyzed using AI, and then generates appropriate triggers. Such a system could detect, it's predictive surveillance that detect early signs of outbreaks and predict spread, support the frontline workers with AI-powered diagnostic tools and clinical decision support systems, trigger rapid response, right people, right place, right time, and right medical countermeasures, guiding the resource allocation and financing, where to deploy oxygen, where to deploy vaccines, beds, etc., ensuring supply chain resilience, and also accelerating development of medical countermeasures. This is not futuristic. It's increasingly within our reach. So the digital health and AI are not really the luxury add-ons, but essential infrastructure that allows a health system to absorb the shock. You saw, we created this telemedicine platform, eSanjeevani and all. Adapt its resources through real-time data and transform into a learning system that can predict the next emergency before it befalls. The India's National Digital Health Blueprint and recently launched the strategy for AI in health provide how to leverage the full potential of digital and AI in healthcare. Fifth, global solidarity. Resilience also depends on global collaboration. And we learned that during pandemics that no one is safe until everyone is safe. So we must ensure equitable access to vaccines, to diagnostics, to therapeutics. COVID showed us what is possible and also where we fell short. Recently, we had a conference organized by CEPI, Coalition of Epidemic Preparedness Innovations, and they have set a goal of 100 days. 100 days from identification of pathogen to vaccine development, clinical trials, regulatory approvals, to production. This cycle used to take close to 7 to 10 years earlier, but now the ambition is to bring it down to about 100 days. Ambitious, no doubt, but possible. And that could save millions of lives and trillions of dollars. However, so when they talked about production, I said that you also need the health system's capabilities to administer those vaccines to all eligible population. And the reason India could succeed in some sense in COVID was that we had the manufacturing capacity and we also had the capacity to administer 2 billion doses because we had health systems that were built to deliver routine immunization on that scale. So the routine immunization that was prepared for UHC was the same system that helped us deliver 2 billion doses to people whom we wanted to provide vaccines. Now, the global efforts are currently underway on pathogen access benefit sharing agreement, which is part of the pandemic treaty. Consultations are going on, and that should succeed to enable equitable access to medical countermeasures. And we are also aware about the global headwinds that are trying to undermine this multilateralism. And lastly, and this is where Professor Reddy mentioned about communities of people. So communities are not really beneficiaries, they are partners. And resilient systems are built on trust and participation. So the community engagement is not optional, it is essential. This is where we heard Dr. Rajan trying to engage with all the Gram Panchayats. So, friends, over the next 2 days, this conclave offers us a powerful opportunity, not just to discuss, but to learn and to act. So, let me leave you with one final thought. Resilience is not about bouncing back, it's also about bouncing forward. We have come together, we are learning together, and now it's time to work together to build resilient health systems that deliver for every person in times of calm and in times of crisis. Thank you.
Thank you, Mr. Jalani. Your words have reminded us once again that while health crises may be local in impact, resilience is strengthened by global learning and shared practice. I now request Dr. Sangamitra Pati to please address the gathering.
Namaskar and a very warm good morning to all of you. On the dais, Dr. Reddy, Dr. Khobragade, Ghosh sir, Jalani sir, Mala ma'am, and Dr. Pandeyji. Of the dais, my very good friend and colleague, Dr. Buputra, Dr. Sudha, and all the familiar faces here. I can't see Maulik maybe. Yeah. So all the familiar faces here, because I always say public health is a very small space. I mean, we keep on bumping each other when there is any event, there is any conclave, or there is any brainstorming discussions like this. So once again, congratulations. I join all my predecessors to congratulating Dr. Reddy for not only being so visionary, but also bringing some disruptive thinking in terms of global learning collaborative. Those three names are so insightful. And when joined together, they are so powerful like your bicycle. And the bicycle also represents the whole is greater than the sum of its parts. So individually, each one of them may not do what they are doing when they're working in coherence, in congruence, and in sync. Very important, because when all the three bureaucrats, in fact, I felt so challenged when you listen to the transformative journey and the illustrative achievements of three bureaucrats. It was a triple challenge for me, because being a scientist, I represent Indian Council of Medical Research. So for a scientist to kind of satisfy the audience when you have heard to the very transformative achievement that states have achieved, including World Health Organization. And that's the power of administration. What we scientists try years to persuade the policymaker to take up something, they can do it in minutes. So it is very important that researcher, visionaries like Dr. Reddy, and policymakers and program and all the think tank, they come together in such platform. And I come from Indian Council of Medical Research, whose primary job is how can science enable policies, programs to take certain decisions which are evidence-based. I always make a mention of a very interesting quote I have read in the Forbes website. I keep repeating. For those who have already heard, please excuse me. Only in God we believe. All others, please bring evidence. So that is the importance of evidence. An Indian Council of Medical Research has, since its inception more than 115 years back, primarily been devoted to generating evidence by conducting epidemiological, observational, and different studies, translating the evidence into products, diagnostics, therapeutics, and more importantly, synthesizing the available evidence and suggesting which makes more meaningful. And most importantly, ensuring or advocating with the program and policy to uptake those evidence for accessible and affordable healthcare. And towards this, because ICMR does not represent the research that ICMR does, it represents the all medical research that the country does. And we do have both intramural, which comprises 28 institutes across the country, and a whole lot of extramural research, which all the other medical institutes or scientific institutes or academic institutes do take up, either to describe a problem or to develop a solution or to deliver the solution to in the primary healthcare setting or maybe any other healthcare setting, and also to discover new knowledge. Because all the predecessors have so much discussed on One Health and pandemic, it also takes me back to that nostalgic time of COVID pandemic, because ICMR was in and out involved in the whole pandemic, starting from its genesis to its still continuing the effort. And when the pandemic struck, because I hear that we are discussing about resilience, I will just give one foresighted action of one of our previous DGs, Dr. Katoj. So when H1N1 pandemic struck, at that time, Dr. Katoj and the whole team of ICMR thought that we should have some mechanism, some setup to see that virus research, because traditionally microbiology departments were doing bacteriology research or some amount of mycology. How can virology research be catalyzed in medical colleges? So towards this, the first concept of VRDL came, that is Virus Research Diagnostic Laboratory. And to start with, some ICMR institutes and some non-ICMR institutes were given the task of setting up VRDLs. And these VRDLs were biosafety level 2 laboratories. So BSL 2 were primarily with National Institute of Virology. It was a 3-tiered structure. National Institute of Virology, which is the premier institute. In fact, we do have presence in Kerala, sir. So National Institute of Virology, which is the apex institute on virology, was the supranational lab or the highest lab. Below it were the regional VRDLs, and below it were the state VRDL. Below it was the medical college VRDL. So this is how the tiered structure was made. But after 2 to 3 years, people were a little bit skeptical about whether these VRDLs are of any use or not. Because after H1N1, we were not seeing much of the viral outbreaks. And then came the COVID pandemic. And it is at that time, all these VRDLs rose to the occasion because they had people or manpower who were competent. They had infrastructure in terms of artificial machines and biosafety level who were ready to test. And most importantly, it was under a dedicated scheme of Department of Health Research, ensuring seamless flow of finance. So these VRDLs not only were entrusted with testing for COVID-19, but also because every day or every alternate day, new labs were being constructed. As sir was highlighting the importance of building blocks. And the most important building blocks we always say is that how do we have the capacity? And capacity comes from two. One is infrastructure, one is manpower who are competent. So these new VRDLs were mentored by the established VRDLs. So a kind of a capacity building cascade was created. And then one fine morning, we were importing all the testing kits from USA and other Western countries. And when it was beyond their control, they stopped exporting their reagents to India. And then came the role of indigenous innovations, or how can we be self-sufficient in terms of producing our own kits. And the kit which we were importing at a cost of 2,500 came down to 150 rupees, all because the affordability was because it was indigenous or we made it ourselves, and all credit goes to at that time to the private sector. So no growth is possible unless there is a harmony between public, private, industry, innovator, researcher, and policymakers. So the very purpose of this global learning collaborative is collaboration, and how can we make sure that all the partners come together for a collective goal. Then came the role of the trajectory of COVID-19. Initially, it was RT-PCR, which took 24 hours. Then came down the duration to 6 hours. Then came the rapid antigen kit. Then came the, what I'm saying is that then came the Omicron kit, only to diagnose one particular mutation. This is the evolution of science, or how science accommodated itself. That is what is resilience all about. How do you accommodate yourself to remain contemporaneous and to address the challenges that are coming in a time-bound manner? So post-pandemic, the effort must continue, because if at all we are trying ourselves that we are a pandemic resilient country. And we do have National One Health Mission, which sir has well highlighted under the PSA office. And very, as the philosophy of One Health is that it does not belong to one department, it's all working together for One Health. It is within the office of the Principal Scientific Advisor, and ICMR is the nodal department for One Health Mission. And under this One Health Mission, the first thing was done is that to set up a dedicated institute, that is National Institute of One Health at Nagpur. Second important is that how can we have surveillance, integrated surveillance, which is very important, or One Health surveillance. For instance, we do have started now wastewater surveillance, which can give early alerts, bidirectional surveillance in zoos, sanctuaries, bird sanctuaries, slaughterhouse. So different ways of integrated surveillance so that we can collect data from multiple sectors and see whether there is any early warning action. Apart from that, mock drills are being conducted, Bishanu Sankraman Abhyas. So mock drills are being conducted regularly. And third thing very important is that under the Prime Minister Ayushman Bharat infrastructure scheme, we are going ahead with setting up BSL-3 laboratories, because the pathogen X, no one knows whether it requires BSL-4, BSL-3 or BSL-2. So some BSL-3, 1 or 2 BSL-4 and majority BSL-2 would be enough to cater to the needs. Now, when we are looking at beyond pandemic resilient, I mean, a system is not resilient only if it is pandemic resilient. A health system is resilient when it addresses all the healthcare needs of individuals. Why I am saying this? Because during the pandemic, the acute infections were taken well care of. And so also the maternal and child health, because we do have a very inherently strong RMN-CHA for which the immunization and other programs were continuing. But there is disruption happened in terms of non-communicable diseases. So when we did a couple of studies on non-communicable diseases, we found that particularly those who are living alone with this empty nest syndrome, the older couples, second, people who are the urban poor, and third, those who are mentally challenged, for example, dementia patients, they were having a huge challenge, not only accessing, but the problem is that, for example, if a dementia patient goes to a hospital, he's not able to take care of himself. And the caregivers were extremely worried that what will happen if he or she gets COVID. And not only that, when we interviewed these elderly people who were living alone, they went back to the same model of GPs. They told that we want someone who should come home and see us and give us a complete care rather than we calling individual specialist. So health system resilience should look beyond pandemic resilience and ensure that irrespective of whatever is the crisis, how the routine healthcare services be implemented the way they used to be. Because it's not that everyone gets affected by pandemic. People were more affected because the dialysis was not being possible during COVID pandemic. People were more affected because the daycare chemo was not possible during COVID pandemic. People were not able to follow or get the drugs that they really wanted to continue for their NCDs. So it's very important that health system resilience takes care of also the nuances of non-pandemic healthcare needs. then only we can speak or we can say that we are resilient. And also that this global learning, I mean, when we are looking at learning, it is important that the spirit of learning should also include some amount of unlearning and some amount of relearning as well. And very recently, I was fortunate enough to attend the Transforming Medical Education conducted in UP, sir. I had the opportunity to meet you also in that. Very important, sir. I would like to appeal, Dr. Reddy, that we should also think or do some innovations or some research around these learning methods. So research in medical education or research in public health, we speak much. But what about research on public health education or research on learning or research on medical education, sir? Being a clinician turned public health researcher, I think you are the best position to spearhead it. My hearty congratulations to each one of you and wish you all, again, once again, I would congratulate and at the same time wish you a 2 days full of learning, unlearning and relearning. Thank you.
Thank you so much, Dr. Pati. Your perspective reinforces the fact that resilience must be evidence-led, innovation-ready, and grounded in scientific rigor. I now call upon Professor Mala Rao to please join us on the podium. I hate to do this, but Mala ma'am and Professor Pandey, we would request you to please keep your addresses to 10 minutes. Thank you.
Thank you. Right. Well, 10 minutes. The clock's ticking, so I better get going. I know that's perfectly good, housekeeping, Stuti. Dr. Krishna Reddy, sir, esteemed colleagues from governments, global institutions, academia, and the Global Learning Collaborative, and friends. I'm honored to be invited to contribute to the inaugural session of this conclave and to be given this opportunity to share some of my perspectives on why health systems resilience remains hard to achieve and to end with a call to practical action. Only yesterday, the United Nations Weather Agency, the World Meteorological Organization, reported that the Earth's climate is further out of balance than at any time in recorded history. It warned that the planet is gaining much more heat energy than it can release, driven by emissions of greenhouse gases such as carbon dioxide, levels of which are at their highest for at least 2 million years. This record energy imbalance heated the ocean to new heights last year and continued to melt our planet's ice caps. Global average temperatures were about 1.43 degrees centigrade above pre-industrial levels last year, and scientists fear that this could soon bring further heat records. Consequently, the UN Secretary General Antonio Guterres recently declared that planet Earth is being pushed beyond its limits, and every key climate indicator is flashing red. And as if that is not enough, the background is that many of the Sustainable Development Goals targets are not on track. The COVID-19 pandemic has undone nearly a decade of progress on life expectancy globally and has profoundly affected socioeconomic, environmental, and health systems. Geopolitical turbulence is at levels not seen for many decades, and new and protracted global conflicts are affecting millions. And then we have the new and potentially existential threats, such as misuse of AI and other forms of technology. So, how are health systems to be strengthened in that rather grim context? There are many guidance documents and reports that have been published on strengthening health systems resilience, including the guidance published by WHO in 2024, which is perhaps the framework that is most used and best recognized worldwide. And I merely summarize what actually my colleague Manoj Jalani was already referring to. These reports define resilience as systems, including the institutions, infrastructure, and populations that are able to anticipate, prepare, prevent, absorb, and adapt in response to and recover from a wide variety of shocks while continuing to deliver health services as needed. They utilize lessons from experiences within and outside their settings to improve their capacities and performance. These reports recommend time and time again, and actually, I was delighted when Dr. Pati was talking about this, that to achieve this resilience, health systems need to ensure that they're robust enough to deliver routine services in the first place, that they include resilience planning within all relevant health systems components, including public health functions and services, and ensure that past lessons are recorded and acted on. But are these recommendations implemented? The answer is no, in general. One very pertinent example was the 5-year review of the UK's response to the COVID pandemic, published last year, which showed that the UK performed worse than many other developed nations despite spending more money on economic help. It has witnessed larger drops in life expectancy, more people too sick to work, and high levels of mental health problems in young people. And although there will be a range of factors to explain these variations, experts have concluded that a key difference is the consistent underfunding of the National Health Service during the previous decade, leaving it without much resilience to cope when the pandemic struck. So, what are the barriers to achieving resilient health systems? Has there been research to investigate this, and what conclusions have been drawn? One comprehensive analysis of barriers, as well as facilitators affecting health systems resilience, is a scoping review published in October 2025 by researchers based in Brazil. The question which the review sought to answer was, what does the scientific evidence indicate as strategies and barriers to the attainment of a resilient healthcare system? The research revealed nothing particularly new, but it just brought it all nicely together when it said that strategies which were mostly favorably associated with strengthened resilience were decentralization of the system, a committed, motivated workforce, good governance and leadership, multi-sectoral partnerships, community involvement, an adequate information system, and investments that favor the sustainability of the healthcare system. In contrast, ineffective management without leadership, inadequate monitoring, an ineffective workforce, a lack of global solidarity, and failure to learn from past experiences were exposed as barriers to resilience. Like me, many of you will have observed these barriers played out in your own organizations, especially because one or more disasters have come our way in the last decades. Decentralization, and again, my esteemed colleagues before me have talked about this, of decision making is a hugely important factor in ensuring flexibility and timely responses to crises. And the decentralization needs to get right down, and I'm delighted others have said this, to the primary care level. But how truly valued are primary care staff in relation to the healthcare system hierarchy? Let's ask ourselves, to what extent do policymakers recognize and routinely involve community-level health staff as equal partners in planning for resilience? I had the honor and privilege of working in Kerala to tweak their primary care model and help them shape it. And I could see that happening there, sir. And I think it's something that the whole world could learn from. How confident are these primary care staff to take action locally, knowing that they would not risk criticism or censure when a disaster strikes and they are at the front line? In England during the pandemic, when the system leaders were challenged with the need to administer vaccination to thousands of people all at once, it was GPs, together with members of the local community, who quietly and without any fuss innovated a drive-through vaccination system where people could drive into a large business park, roll down their windows, roll up their sleeves, get vaccinated, and drive away. Local businessmen lent their buildings to the health staff out of respect for what they were trying to do, and thousands, including me, could be vaccinated daily. A linked issue relates to community engagement. Hostility to COVID vaccination in the UK exposed how little trust and confidence many communities had in the health system, which had simply not thought to build that partnership of equals in normal times. Nurturing the allyship of communities and giving them ownership of strategies to help address disasters is a benefit not merely in times of crises, but also in increasing compliance with care at all times. Resilience also calls for leaders who always respect their teams and staff and enable them to be partners in decision making, not just during a crisis. How else can we build a strong, motivated, confident workforce that's ready when disasters strike? A robust health management information system is also listed as an essential component of resilience strengthening. Yet, during a heat wave in the UK in 2022, a very prestigious London hospital was reported by BBC News to be literally in meltdown after its IT system was knocked out during a heat wave. Operations at Guy's and St Thomas's hospitals in South London were cancelled after IT servers broke down at 40 degrees centigrade temperatures on 19 July 22. A member of staff told the BBC poor planning and chronic underfunding were some of the explanatory drivers. Without a functioning IT system, staff had to return to paper notes for a while. My practical question is this: have we adequately imagined whether IT systems and AI, as well as other parts of the health system, will continue to function as global warming intensifies and natural disasters become more severe and more frequent? What happens when we are neck deep in water? And where is the multi-sectoral collaboration at all levels, including at the global level, to address risks requiring interdisciplinary collaboration and cross-boundary collaboration? Transboundary threats, as others have said, such as infectious disease and pollution, are examples of such risks. So, in conclusion, understanding the facilitators and barriers is fundamental to achieving a resilient healthcare system capable of dealing with chronic and acute stressors. Addressing the obstacles requires practical actions, many of which actually do not need significant financial investment, but just the commitment to establish resilient, equitable healthcare systems, to put aside our egos and turf wars and work with humility together because the public deserves it. With the scale of threats we face going into the future, it is time that we were bold and ambitious in our efforts to strengthen the resilience of our health systems. And before I truly conclude, I want to put in a word for women and the greater participation of women and more gender equality at every level of planning and in community engagement. Because women are intuitively more inclined towards participatory networks. And there is a massive evidence that, for example, in the Honduras, where in one part of, in one town, when the women were trained in how to operate the early warning systems for disasters, beyond that time, nobody died when hurricane struck. It's also known that where there are women's and environmental NGOs proportionately higher than in other parts of the world, the deforestation loss tends to be less. And so the evidence goes on about the benefits of gender equality and greater levels of women participation in all levels of resilience planning and building. Thank you so much for listening.
Thank you so much, Professor Rao. Your remarks remind us that resilient health systems are not only built through strong institutions and sound policy, but through a sustained commitment to equity, inclusion, and global solidarity. I'm sorry. I now request Professor Brajesh Pandey to please come up to the podium and address the gathering. Thank you.
Namaskar, distinguished guest on the dais, esteemed colleague, and member of the Global Learning Collaborative. uh, Good morning. It is pleasure to welcome you all in the Indian National Science Academy for this fourth annual conclave of the Global Learning Collaborative for Health System Resilience. We are honored to host this important gathering and to bring together such a diverse and distinguished group of expert, practitioners, and thought leaders. At the utmost, at the outset, let me commend the organizers for the curating a platform that address one of the most pressing challenges of our time, the resilience of the health system in the increasingly uncertain and complex world. The past few years have made abundantly clear that resilience is not merely about responding to crisis, it is about anticipation, adoption, and continuity. In resilient health system is one of the absorb shocks, learn from the absorption, and continue to deliver essential services under all circumstances, whether facing pandemic, climate-related event, or long-term socio-economic stresses. In this context, the role of science and evidence become central. Scientific institutions like INSA have a unique responsibility not only to generate knowledge but also to ensure that this knowledge is translated into real world impact. Bridging the gap between research, policy, and implementation is not optional, but this is essential. At INSA, we have consistently sought to move from knowledge generation to knowledge application. Our engagement with Niti Ayog on enhancing the ease of doing the research and development in India is one of such example, where scientific evidences has directly informed policy reforms. By bringing together researcher, industry, stakeholder, and policymaker, we have contributed to identifying scientific challenges and recommending practical solutions to strengthen the research ecosystem. Building on this approach, INSA has also been advancing initiatives such a scheme like Arani, Accelerating Research and Networking for Innovation, which aims to strengthen collaborative research ecosystem and promote the translation of scientific acknowledge and actionable outcomes. Through Arani, we are fostering partnership, enabling knowledge is exchange, and supporting evidence-based policy making, ensuring that research does not remain confined to academic outputs and contribute meaningfully to social economical developments. This reflects the broader role of Indian National Science Academy is not just a promoter of scientific excellence, but as a key institution at the interface of science, policy, and society. Since its establishment in 1935, INSA has been actively advising government bodies, fostering international collaboration, supporting science communication, and advancing initiative and align science with the national priorities. At the same time, we must ask ourselves, how can evidence inform real-time decision making? How can research be made more responsive to ground realities? And how can institutions serve as trusted intermediaries between science and society? We believe that interdisciplinary collaboration is key. Health system resilience cannot be addressed in silos. It required convergence of biomedical sciences, data sciences, social sciences, and policy research. Equally important is the need of strengthened partnership. Scientific and academic institutions must work more closely with government, healthcare providers, and communities. Only then we can ensure that knowledge does not remain confined to report the publication, but evolve into deployable and scalable solution. India, with its vast and diverse public health ecosystem, offers unique opportunities for innovation. From digital health platform to community-based interventions, we have demonstrated the context-specific and scalable model can make a significant difference. However, there remains a need for deeper integration, stronger coordination, and sustained capacity building across the system. In this spirit, it is equally important to ensure that our initiative are supported by adequate and timely resources, enabling continuity of research, strengthening institution capacity, and sustaining the momentum of impactful program. This conclave provide a valuable opportunity to reflect on these challenges and to collectively shape pathway forward. Let us use this platform to share lesson across the geographies, build meaningful collaboration, and translate knowledge into action for more resilient health system. In closing, I once again welcome you all at INSA and wish this conclave great success. I am confident that this deliberation over the next 2 days will generate valuable insight and actionable outcomes. Thank you.
Thank you so much, Professor Pandey. The GLC for HSR Annual Conclave 2026 is now formally inaugurated. We thank our distinguished guests on the dais and all of you in this hall, and also those joining us virtually for honoring this moment with your presence. Thank you, sir. Thank you, ma'am. Thank you so much.